Hello. On behalf of the Mountain Plains Regional Disaster Health Response System, welcome to this ninth module of our 9-part series of the Be Nice Weapons of Mass Destruction program. This discussion will focus on the principles of decontamination. We're going to talk about the methods to provide decontamination. We'll talk about the indications for doing so at a WMD event. Basically, let's talk about the definition. It's designed to make a person or equipment safe by eliminating or reducing toxic materials. That includes chemicals, that includes biologics, and radiologic material. Every responding agency, both field responders, hospital responders, need to have a procedure, a protocol in place for determining their decon process. When decon is needed, what resources are available to provide that decon, and what concerns have to be addressed through planning processes. Every decon station should have a number of items in their protocol. An evaluation process for which people require decon and the order in which they should be deconned. Those who have the highest risk of contamination to toxic materials should be deconned immediately. Personal property has to be handled, and potentially evidence is going to need to be collected. Decontaminate as soon as possible. Now, many references suggest the use of diluted bleach solutions. The reality is water, and lots of water, is usually adequate to deal with virtually all contaminants. And decontaminate what's necessary. Not everything needs to go through the process. As much as possible, decontaminate as close to the scene, as far forward as possible. This will hopefully prevent contaminated individuals from leaving the scene of the incident and then potentially causing secondary contamination. And decontaminate by triage priority. Those who are showing signs and symptoms should be decontaminated first. And you can expect, based on past experience, almost 5 times the number of people who are unaffected to present compared to the affected people. And they'll have to be dealt with. And victims have to understand that disrobing is part of the process. Taking clothing off is a critical step in the decontamination process. Well, let's talk about decontamination operations. First off, there are 2 types of decon. There's emergency decon and technical decon. Technical decon is the decon that is performed to deal with contaminated supplies and equipment. We're not going to really focus on that in this presentation. We're going to focus on emergency decontamination. Emergency decon are the actions that you take in order to deal with patients or victims, and it's based on speed of process and not neatness. It's used for those who have been exposed. It's designed to really minimize the ongoing clinical effects, potentially to save a life. We want to remove as much of the agent as possible from the victim's skin and clothing to eliminate ongoing exposure and continued clinical signs and symptoms. It will prevent subsequent cross-contamination for both emergency responders, transporting personnel, and hospital medical personnel. And frankly, it's useful for those who are concerned that they were exposed but aren't showing signs or symptoms but at least they've gone through the decontamination process. Now, in order to do this, one has to have priorities for decon and deciding who's going to go first and what order patients are going to be deconned. Those that clearly were contaminated and require prompt medical attention because of the signs and symptoms they're demonstrating should be deconned first. Those who are exhibiting signs and symptoms of agent exposure but are milder are next. Those who are contaminated but not showing any signs and symptoms, not in urgent need of medical attention, are third. And then those who might have been contaminated but still have no signs of agent toxicity are next. There are a number of considerations to think about when doing this. Number one is, how long will it take for each individual to be deconned appropriately? This has implications on whether someone is ambulatory or non-ambulatory. What's the weather? Is it warm? Is it cold? Cold weather operations throw a wrench in things because of the potential for hypothermia. Every patient being deconned who is going to pretty much be self-decontaminating themselves has to be given specific instructions on exactly what they should do, what process they should follow to decontaminate themselves. Are you going to separate women from men? Okay. Or, is that possible given their supplies and equipment? How are you going to manage personal items? Some of those will actually need to be discarded. Others may be decontaminated. Modesty is always an issue, both during the decontamination process and afterwards when you want to redress someone. And the issue of news cameras, etc., and protecting patients from those prying eyes. And then for those that are demonstrating clinical signs and symptoms, how are you going to evacuate them? For the responders, a number of issues that we have to think about. First of all, the PPE. The responders must wear PPE appropriate to their role. If a responder is going to go into the hot zone where the actual incident occurred, they have to be using appropriate PPE, most likely level A. If you are going to be in the decontamination area, in most cases, we're talking level B protection. Once someone is decontaminated, then the PPE that's used would be pretty much standard universal precautions. How much contact are you going to have with individuals? What's your triage process going to be? And how do you assess those patients for signs of toxicity? When you respond to the scene and you set things up, you want to be sure that you're setting them up upwind. If you're setting up hose and lines, where are those going to be placed? Your transport and staging area, again, where's it going to be? It should be upwind and uphill. Are there agent-specific procedures that need to be implemented? And finally, what are you going to do about the runoff of the decontamination process? And we'll talk about some of these. PPE, as I said, depends on the role. The rescue and extraction personnel, frankly, need to have the highest level of protection, and that's level A. The decon personnel, in most cases, can use level B protection. Minimize contact as much as possible. Monitor yourself and your coworkers for any signs or symptoms, and you should consider yourself contaminated as you deal with this process. Module 2 in this series has additional information about PPE, so you might want to take a look. Decontamination operations, as I mentioned, are influenced by how many patients are ambulatory versus non-ambulatory. The ambulatory patient requires less manpower. You need someone to give them instructions about how they're going to decon, but they don't have to be physically deconned by someone. Non-ambulatory patients, on the other hand, require more manpower, both to undress them and to then decontaminate them. Additional concerns. You want to coordinate early with law enforcement. You'd like to have an appropriate perimeter set up to prevent people from wandering in and perhaps preventing people from wandering out until they have been decontaminated. In addition, an incident like this is a law enforcement incident, and evidence collection becomes an important consideration. Site security, another reason to coordinate with law enforcement. Evidence collection. As you undress patients, all of their belongings should be collected, bagged, and labeled. The general process depends on whether or not an agent is a wet agent or a dry agent. Most of the chemical agents are wet, and so if there's obvious liquid on someone, typically that'll get blotted up. If, on the other hand, the material is a dry agent, very often you would then wet the patient to prevent that from aerosolizing and having them inhale it. Excuse me. Then have them remove their outer clothing and flush them with water, and then recover them once you're done with the process. Some folks skip the blotting process and go straight to strip and flush. And again, high volume, low pressure, water, lots of water is adequate for most of these contaminants. This is what this might look like. You've seen this before, but the incident site is to the left, and that will be downwind from where everything else is being done, and also downhill if it's on an incline. Patient triage will be done in the hot zone. Clothing removal occurs at the border between the hot zone and the warm zone. The warm zone is the decontamination area. And if there are ambulatory and non-ambulatory, there may be two separate lines. Then you will transition to the cold zone where treatment can be provided and then transport as necessary. All of these various zone borders should have access control points so that contaminated individuals don't get beyond where they should be, and non-contaminated individuals do not inadvertently enter one of these zones and become contaminated. Now, decontamination corridors at a scene. Fire equipment is a very useful tool to use for decontamination purposes unless portable decon tents and that sort of thing are available. And it also provides a focal point for victims to move towards when the decontamination process is begun. This is what it might look like using fire apparatus. The contaminated victims in the hot zone remove their clothing. Clothing is kept in a holding area labeled with the victim's name. The victims walk towards the right between two fire apparatus, which have hose set up and low pressure, high volume water showering, basically. You also see a ladder truck that could have a higher hose placement. And again, high volume, low pressure. And then they walk through this. It's visually apparent to them what they're going to do. And then decontaminated patients can then get moved to the treatment and transport areas. This is what it might look like. You can see two engines, one on the left, one on the right, with low pressure, high volume sprays occurring, and victims can walk through this and get showered. And again, it provides a sense of direction. It provides, a visual instruction for how they should proceed. The use of tarps is very useful to prevent the prying eyes, the helicopter in the sky from the local news channel, etc., and provide a modicum of modesty to these individuals as they get deconned. And again, this is sort of what that looks like with the tarps in a graphic demonstration. And additionally, if resources are adequate, you could have multiple corridors established for both ambulatory, non-ambulatory, for men and for women. And again, tarps provide that degree of privacy that are nice. In this photo, you can see the hose hanging from the ladder to provide for low pressure, high volume shower. And here you see a ladder pipe decontamination system with a high volume shower capability. Non-ambulatory rapid decon can be done just as you see in this photo. Of course, the one concern with something like this is that the runoff is contaminated and these individuals are lying in that runoff. So you really want high volume and you'd like to get them off the accumulating runoff as soon as possible. This is an example of a commercial decontamination tent, 2 lines, one for women labeled as such, one for men. And again, you see the baskets, they can have sponges and that sort of thing. And patient clothing bags, patients can get undressed just before they enter it, bag their clothing, and then proceed through the decontamination shower. This is an example of a commercial tent, but for non-ambulatory victims. You can see the roller setup that will ease the passage of these individuals through the decontamination tent. In addition, the nice thing about using a roller system like this is the runoff does not stay underneath the patient, but it flows through the rollers down onto the ground. So the patient is not laying in that contaminated runoff. But again, this is a very manpower intensive to move the patients along, to undress them, and to decontaminate them. In cold weather, there are dry decon techniques that can be used. An alternative is a quick rinse outside and then move them into someplace warm for a more thorough shower. If there are indoor structures that are available to you, perhaps you can make use of them. Parking structures, shower and locker rooms may be used. Some building sprinkler systems could be used as well. Swimming pools also provide an opportunity for a large volume water that would dilute contaminants. So I mentioned using water a couple times. Water is available. There's no downside to using water, and most of the agent can get removed by the mechanical action of showering. Soap and water helps remove more agent depending on the agent. It does take time to mix. You may have to go get it. There's extra cost associated with it, but again, there's no downside to it. Bleach, diluted bleach processes does take time to mix and there is cost associated with it. This probably helps remove and neutralize more agent, again, depending on the agent, but it has the downside of potentially causing skin irritation and damage. And if you do irritate and damage the skin, the potential for allowing more of that contaminant to then enter the victim becomes very real. So for emergency decon, quite frankly, the benefit of quickly showering just with water outweighs any potential benefit of using soap or bleach solutions. Patients should go through decon even if they think they have already self-deconned themselves, under the watchful eye of an emergency responder who instructs them. It's preferable than just accepting the word that they decon themselves. Most ambulatory patients can go through decon with minimal assistance and just direction from attendants. Those are impaired, obviously we already said, will require special assistance. Things to consider: males and females, ideally separate decon facilities if possible. Young children should go with whichever parent they choose, and if they can walk, they should walk on their own. Okay, we've talked about the priorities for which patients should be done first. Okay, personal property needs to be collected and labeled. Clothing. The act of removing clothing is thought to remove somewhere between 75 to 90% of the contamination. So it's a crucial step in the decon process. And patients who are reluctant should be informed that this is an essential step. Any clothing that normally would come off over the head and face should be cut off instead. You don't want to have the patient risk the possibility of inhaling more of the contaminant or re-aerosolizing some of the contaminant, breathing it in, and then increasing their exposure. Excuse me. If for some reason the clothing can't be cut off, victims should be advised to hold their breath while the clothing is removed over their head. And you know, if someone is absolutely adamant that they're not going to get undressed, well, you can decon them with the clothing in place. However, you know, warn them that, in fact, it may be incomplete. You may spread more contaminant onto skin by doing it this way. Whereas if you get rid of the clothing right off the bat, you're getting rid of 3/4 to 90% of the contaminant. Personal items, I mentioned, should be bagged and sealed. The bag should be impermeable to whatever the agent is, and then secured for later either disposition, potential discard, and possible decontamination, and some may prove to be evidence later on. Eyeglasses and contact lenses. Basically, contact lenses ideally should be removed with a contact lens remover if it's available, so that you don't put any potential contaminant into the eyes. Hands should be washed before removing contact lenses. And they are not deconned. They get disposed of. Eyeglasses in metal frames can be deconned. Eyeglasses in plastic frames should be placed in bags, labeled, and later disposed of. Everyone going through the process should get instructions. They step under the shower, they flush their face, hair, and eyes with lots of water, and then wash the face and the rest of the body after that. Following the shower, personnel should check these individuals for any evidence they continue to have exposure, any ongoing signs or symptoms of toxicity, and perform a good medical screening exam. If there are persistent signs or symptoms of toxicity, the decon process ought to be repeated. Mustard victims. I mentioned this in the chemical talk, but mustard patients should be deconned even if they are not showing signs or symptoms for a couple reasons. Number one is signs and symptoms are delayed, so they may not realize they were exposed. Number two is it prevents cross-contamination of providers, caregivers, and other responders. And the moist areas, body crevices, under the arms, under the breasts, under the scrotum, between the buttocks, are very susceptible to mustard. And so those need to have special attention paid to them to be sure they are washed and deconned. Once decon has been confirmed, patient proceeds to the evaluation area for any first aid that needs to be provided. They are redressed. They are monitored for any signs of ongoing clinical toxicity, treated for any injuries, and then patients need to be watched. If this is a nerve agent victim that was a vapor, at least 30 minutes. If it was mustard, for 4 to 6 hours, because that's the delay period. Other agents, for the most part, can don't require long periods of observation, except for things like phosgene, which frankly patients ought to be watched for 12 to 24 hours. Obviously, deconned persons should be kept separately from the non-deconned individuals, and there's no point to letting the two mix other than complicating your life. In some cases, you may allow certain uncontaminated persons, such as parents, to join deconned children. Each deconned person should be provided with a decontamination document, if you will, that indicates when they were deconned and what was done to do that, when it was completed, their period of observation time, and any treatment that was provided to them. Pretty much like a triage tag. The non-ambulatory decon, proper PPE has to be used. The patient has to be removed and carried. Their stuff has to be isolated. Dry particles are brushed away. Visible liquids are blotted away, and then they go through the decon process. They're rinsed with water, ideally warm if available, low pressure, etc. Washed with mild soap if it's available. No neutralization products, just water and soap if at all possible. The order of decon for the non-ambulatory is the face, eyes, and head first. Any areas that sustain trauma, soft tissue damage, obvious areas of gross contamination should be watched first. Then the anterior body, then the patient turned up on their side, and the posterior surface of their body washed. Now, care during decon is for the most part pretty minimal. Obviously, bleeding control can be relatively straightforward. It's easy to apply a tourniquet and quick to apply a tourniquet. So hemorrhage control is something that ought to be considered. Airway control, relatively simple interventions such as airway positioning and spinal motion restriction as indicated. And if available, and depending on the agent, if there are antidotes, you may consider the use of those as well. To run a decon station, you got to have a lot of stuff. And this list is a basic list of what needs to be there. PPE for your providers, bleach, soap, water. Water should be probably the first on that list. Scissors to cut clothing off, cloth, buckets, impermeable bags, tags to mark things, clean clothing to redress the patient, bandages as necessary, and then the rollers or wire stretchers for patients that are non-ambulatory. Each decon station should be able to be set up quickly, staffed quickly, be able to screen people for signs of toxicity, and be able to decon while doing life-saving first aid as necessary. And in order to accomplish this, it requires practice. It requires exercise. So this is not something that should be done only once when the incident happens, but responding agencies, hospitals, etc., should exercise their decontamination station processes. And of course, like anything else, once you start it, you need a method to terminate it and determine who's responsible for doing so. And then at the site itself, at the incident site, who then becomes responsible for decontaminating the incident site. Now, one of the big questions that always arises is what do you do about the runoff since it is contaminated with whatever the agent is? Do you collect it all or do you let it go down the sewer? This was an article that was published some time ago about first responders' environmental liability due to mass decontamination responsibility. At one time, the EPA said that all runoff needed to be collected. Well, let's talk about reality for a second. If you have a very small number of victims, just a couple, it's possible to collect the runoff and probably should be done. On the other hand, if you have a big incident with a large number of patients, the reality is they don't make a container big enough to hold all the runoff. So the recommendation is let it go down the sewer. Single victim collected, mass casualty incident, let the runoff go down the sewer. Number one is that runoff is going to be quite dilute anyway. It goes down the sewer, it gets further diluted. If you are very concerned about the agent going into the sewer, you can also run another fire hose to the sewer and further dilute the runoff. But for the most part, that runoff is going to be so diluted that it poses minimal, if any, risk. So to summary, DECON appropriate PPE must be used by everyone involved in the DECON process. The DECON process should be performed as soon as possible after exposure to whatever the agent is. The first step, and perhaps one of the most important steps, is removal of clothing, external clothing, which gets rid of a significant percentage of the contaminant. In most cases, water by itself suffices to accomplish DECON. You can add soap in if it's easily available. Dilute bleach, again, complicates things a bit because it irritates the skin. So generally, it's not highly recommended. And after DECON, victims should continue to be observed for signs that either the DECON was incomplete or they have ongoing signs of toxicity. Thank you very much for your participation in this 9-part series. If you didn't see some of the other ones, they're available for viewing. Thanks and take care.